Thank you, Nikos, for this kind introduction. I would like also to thank Professor Kotses for this kind invitation. So we're going in the next few minutes to discuss this topic by presenting and discussing some interesting, I think, cases of patients with diabetes and dyslipidemia. The first case is a 55-year-old man with a 12-year history of type 2 diabetes. He has an HbA1c of 6.5 while on metformin and an SGLT2 inhibitor. Unfortunately, he currently smokes 10 per day. He is obese, a BMI of 32. He has well-controlled hypertension, 120/70. The GFR is good, 80 ml per minute. And the ACR, the albumin to creatinine ratio is 12. No other microvascular complications. Regarding lipid, he is on no lipid-lowering medication, and he has an LDL of 110, triglycerides 210, HDL 34, non-HDL 152, ApoB 98 milligrams per deciliter, and lipoprotein little a 28 milligrams per deciliter. He is on no statin because it was thought that this LDL cholesterol was nice for this patient. Therefore, what do we see in this patient? We see that he has this lipid atherogenic triad of an LDL which is relatively good, 110, but we know that this LDL is from a qualitative point of view abnormal, has small dense LDL particles. He has elevated triglycerides and low levels of HDL cholesterol. This is because of the insulin resistance. We now have the 2023 ESC guidelines for the management of the cardiovascular disease in patients with diabetes. And we now have 4 categories of cardiovascular risk. We have to put every patient in one of these 4 categories in order to decide which is the most appropriate LDL cholesterol target. So we have a very high risk category. This includes patients with clinically established atherosclerotic cardiovascular disease or severe target organ damage, and we're going to describe which is severe target organ damage in the next slides, or a 10-year history for cardiovascular events of above 20% using this novel score, the score 2 diabetes. Then we have the high-risk category. This includes patients with a 10-year ASCVD score of between 10 to 20%. The moderate risk category includes patients with a 5 to 10% score for fatal and non-fatal cardiovascular events. And we now have a low-risk category. We did not have this category in the previous guidelines with a 10-year risk of below 5%. And this is now the scheme we follow. We first ask if the patient has established cardiovascular disease or severe organ damage, and then if the answer is yes, then the patient automatically belongs to the very high risk category. If the answer is no, then we have to calculate the score 2 diabetes. And if the score is above 20%, then again, the patient falls into the very high risk category. If the score is between 10 and 20%, high risk. If the score is between 5 and 10% is moderate risk. And if the score is below 5%, then the patient belongs to the low risk category. And again, this is in order to define the LDL cholesterol target, because for the very high risk categories below 55, the LDL cholesterol should be below 55 milligrams per deciliter. For the high risk, below 70, and the moderate risk category should be below 100 milligrams per deciliter. This again, we have to also reduce the LDL cholesterol by at least 50% for those belonging at the very high risk and high risk. And we have a secondary goal, which is the non-HDL. If we subtract the HDL by the total from the total cholesterol, and that this target is, as in the past, 30 milligrams per deciliter higher than the target for the LDL cholesterol. We now have to define what is a severe target organ damage. This includes an eGFR of below 45, irrespective of the degree of albuminuria, or a GFR between 55 and 60, and the presence of macroalbuminuria, which means albumin to creatinine ratio between 30 and 300 milligrams per gram, or the presence of gross hyperproteinuria, this ratio is above 300 milligrams per gram, or the presence of 3 at least microvascular complications, which include macroalbuminuria and retinopathy and neuropathy, for example. So in the presence of any one of these 4 situations, then the patient has severe target organ damage and belongs to the very high risk category. In all other cases, we have to calculate, as we said, the score to diabetes, and the score to diabetes can be found in the application provided by the European Society of Cardiology. We go here to the up to 10-year risk calculators, and we find the score to diabetes. Our country belongs to the intermediate moderate risk countries, so we have to choose that we are in a moderate risk country, and then we calculate the score, and the score is, in this case, 15.6% for a fatal or non-fatal cardiovascular events during the next 10 years. So we go back to this scheme. Our patient belongs to the high-risk category. This is because he had no severe target organ damage, no established atherosclerotic cardiovascular disease, but he had elevated score between 10 and 20%. Therefore, the target is below 70 milligrams per deciliter and at least 50% reduction of LDL cholesterol. This is the target. We are here in 110 of LDL cholesterol. This is not good. We should go down to below 70 plus a 50% reduction of LDL cholesterol. Therefore, this means that we are going to prescribe a high-intensity statin treatment, such as rosuvastatin 20 milligrams, for example. This will lead to a 50% reduction, and LDL will go down to 55. This is less than 70, which means that is okay and better for the patient. Also, the high-intensity statins produce a good response to triglycerides, and at least 25% reduction we saw here, and triglycerides went down to 158. A small and non-significant, I believe, increase of HDL cholesterol, but a great decrease of non-HDL cholesterol, which is now 75, which is less than the target, which is okay. We also had to consider the lipoprotein little a, which is a mysterious brother, as this slide says, of LDL, which is an LDL plus this apolipoprotein, then apolipoprotein A, which is bound to this LDL particle. And this forms the lipoprotein A. And we know that this is a well-established risk factor for cardiovascular events, genetically determined. If the concentration is below 30, as in this patient, the added risk is low. But if it is between 30 and 50 milligrams per deciliter, the risk is intermediate, and above 50 milligrams per deciliter, the risk increases. And this should be taken into account in calculating the risk. Because for a given level of risk, the presence of increased lipoprotein A multiplies this risk. For example, if you have an LPA little a of 50, then you should increase the risk, multiply the any given risk for traditional risk factors by 1.4, for example, which means that some patients belonging to the high risk category may now belong to the very high risk, or those belonging in the moderate risk category will go up to the high risk category. And actually, there is an artificial intelligence tool which can be found for free in the internet. It's called lipoprotein little a clinical guidance, and this gives information for lifetime risk, not that just for 10-year risk. And this also takes into account the elevated lipoprotein little a levels. For example, this patient has a lifetime risk of 29%, But if you take into account that he has an Lp(a) of 72 milligrams per deciliter, then the risk increases to 40%. And this can be shown to the patient, and you can take decisions for more aggressive lipid and other lifestyle, etc., risk management. And we now, of course, have a lot of molecules to lower this lipoprotein (a), which are in clinical phase 3 studies, and we're going to have these results from 2025 and on. So we will have more information about decreasing by therapeutic agents of these increased levels of lipoprotein (a) to see if this translates into clinical benefit. The second case is a 65-year-old man with a history of type 2 diabetes. Unfortunately, he suffered an acute coronary syndrome 3 months ago. He was discharged on rosuvastatin 40 milligrams and now presents with an LDL of 70 milligrams per deciliter, triglycerides 141 and HDL 39 milligrams per deciliter. It's obvious that this patient should be on a target of below 55. He is not, and therefore we should add something more. And this is something that has proved that lowers cardiovascular risk. We have to cover at least 22% extra reduction in LDL cholesterol, and this can be achieved, at least in this case, by adding ezetimibe. Ezetimibe, for example, in the IMPROVE-IT study, which included patients with acute coronary syndrome, like this one, ezetimibe lowered LDL cholesterol from 65, which was the initial LDL on statin, while on statin, to 46, and this was translated in patients with diabetes to a 14% further reduction in cardiovascular risk. Therefore, it's a well-proven and cardiovascular risk lowering medication, which can be given to this patient as a single pill, because we have single pill medications with rosuvastatin and atorvastatin as well. And this is the new guidelines for the acute coronary syndromes, that what they say is that combination treatment may be given at least at presentation of an acute coronary syndrome, and not just follow the traditional scheme of giving a first statin and then ezetimibe. Sometimes we can give, at least from the beginning in an acute coronary syndrome patient, combination treatment with statin and ezetimibe in order to lower LDL cholesterol earlier and going much lower than a single statin alone. The third case is a 59-year-old diabetic woman, HbA1c of 7.3. This woman has complications, macrovascular complications, such as diabetic retinopathy and neuropathy. Also, severe kidney disease, albumin to creatinine ratio 200 milligrams per deciliter, while eGFR is still preserved. And she is on atorvastatin 40 milligrams, having an LDL on target 55 milligrams per deciliter, but low HDL 34, increased triglycerides 210, and increased non-HDL 97 milligrams per deciliter. Here we have a patient who receives high-intensity statin treatment, is on LDL cholesterol goal, but triglycerides are increased, and HDL cholesterol is low, which is often an often clinical scenario. In this case, guidelines now suggest to administer a high-dose icosapent ethyl, which is 2 grams 2 times daily, in combination with statin or statin plus ezetimibe. This is a pure eicosapentaenoic acid in a ethyl form. This is why, because of the reduced trial, which has shown that in such patients with either established cardiovascular disease or diabetes and other risk factors, icosapent ethyl reduces by 25 further the cardiovascular risk, cardiovascular death, etc. Therefore, it is recommended in the guidelines. What about fibrates? Fibrates, of course, lower triglycerides, but have not been proven to decrease cardiovascular risk, such as the prominent study for pemafibrate. Fibrates have, however, shown that they can decrease microvascular complications. In the prominent study, pemafibrate reduced the incidence of ischemic ulceration or gangrene of foot by 37%. And this was also seen for fenofibrate, which has been shown to decrease, for example, the risk of the progression of diabetic retinopathy, also the risk for good attacks. Therefore, fibrates have a role probably in reducing microvascular complications, but they don't have a role in reducing cardiovascular risk. However, icosapentathil can reduce also cardiovascular risk, so it is preferred after a statin in such very high risk patients with diabetes. And now we have a lot of agents that are in clinical trials to reduce triglycerides while on a statin. For example, angiopoietin-like 3 inhibitors and ApoC3 inhibitors that have been shown to reduce triglycerides, and now we remain to see if they reduce cardiovascular risk. And the last case is a 65-year-old man, type 2 diabetes, smoker, symptomatic lower extremity arterial disease, baseline LDL of 150. Sorry. And this patient, unfortunately, is statin intolerant. He has suffered severe myalgias following the commencement of at least 3 different statins, even at low doses, and any other causes of myalgias have been excluded. Now he is on ezetimibe 10 and pitavastatin 2 milligrams every second day, which is tolerable by the patient, this scheme, but LDL is 110, which is, of course, above the limit, the target of below 55. Then the guidelines suggest that if the patient cannot tolerate the usual high-intensity statin scheme, then we could add a PCSK9 inhibitor to ezetimibe to further reduce cardiovascular risk. And this is what we did in this patient. We asked and granted permission to give evolocumab or alirocumab every 2 weeks, or even inclisiran every 6 months, which is the new kid in the blocking PCSK9 inhibitors. And these drugs work very well. They reduce triglycerides by the LDL cholesterol by 50 to 60%, and now the LDL is on target, 50 milligrams per deciliter, and no muscle symptoms, while the patient is continuing to take this alternative day statin and ezetimibe. Of course, we have the bempedoic acid, which has been shown to decrease cardiovascular events in patients with statin intolerance. Unfortunately, this agent is not available in our country, but it is available in most European countries and therefore can be used in addition to ezetimibe for those patients that are statin intolerant. It is associated with a small 20% reduction of LDL cholesterol, but again, a good reduction of cardiovascular events. And finally, regarding type 1 diabetes, we don't have so many data as for type 2, but we know that this also type of diabetes is associated with increased incidence of cardiovascular disease, and we should treat them patients aggressively in order to decrease their risk. Regarding the use of lipid-lowering medications, guidelines suggest that for all patients with type 1 and an age greater than 40 years, this should be on a statin. Also on a statin should be those younger than 40 years, but with other cardiovascular risk factor or presence of target organ damage disease or a risk above 10%. And this risk can be calculated by a Scottish-Swedish risk prediction model we have for predicting cardiovascular disease in those with type 1 diabetes. And finally, these are the guidelines from the Hellenic Atherosclerosis Society for the management of dyslipidemia. And this is the algorithm we follow here in Greece. So we say that statin should be our first case, of course, drug, high intensity when the risk is high or very high. And then we should uptitrate to the maximum intensity or the maximum tolerated. And if the patient is not at goal, therefore ezetimibe should be added as a fixed dose combination. But we say here in the footnotes that if the patient has an LDL of about 110 and the patient has established cardiovascular disease, then we should start immediately with a combination of high-intensity statin plus ezetimibe as a fixed dose combination compared to wait for first the statin and then the ezetimibe. We can, in some circumstances, start right from the beginning with a dual combination. And finally, we have the PCSK9 inhibitors for patients with established atherosclerotic cardiovascular disease or familial hypercholesterolemia or statin intolerant and high risk, and the LDL above the threshold, which is 100 for our country, for these patients be reimbursed by the national system, or 70 if they have multiple cardiovascular events. And when the LDL cholesterol is at goal and the triglycerides are elevated, then for those patients with diabetes risk factors or established cardiovascular disease, icosapent is the drug of choice, 4 grams per day. And for those that triglycerides remain above 200 and have diabetes, especially if they have macrovascular complications, fenofibrate can be considered. And this is the final slide, and just to say that we have an advanced EAS course that is going to be in Athens on September 27, this September. And also we have our Pan-Hellenic Congress in Ioannina on December, and this 94 EAS Congress is going to be held in Athens in 2 years from now. Thank you so much.